Good afternoon, good morning, good evening to everyone. We're in a webinar, so you won't be able to speak, but please feel free to drop a greeting and introduce yourself in the chat, and we will get started in the next minute or so. Good to see some of my friends in the room. Hi, Anna. Hi, Carlos. Hi, Albert. And for most of you, you should know that, hey, Anna, we are recording, and this is being broadcast live on YouTube. Hi, Michelle. Hi, Lisa. Great to see colleagues from WHO, Human Rights Watch, friends from Yale, UMass Boston, colleagues from Indonesia. Great to see you all. Okay, so I'm going to go ahead and get started. We only have an hour, but today my sort of vision for the next hour is that we will hear from our wonderful speaker, Kat Brooks, for about 20-25 minutes. And then Kat and I will have some dialogue back and forth with some questions that I've already received from colleagues. Hey, Jake. And then I'd like to open the floor for Q&A. You are welcome to drop any questions you have in the chat function, as well as the Q&A box. We'll be monitoring that throughout. And you can also DM me if you feel like that's not going to work and you'd like for me to ask a question on your behalf in an anonymous way. No problem. But great to see you all, and I really look forward to today's conversation. My name is Julie Hanna. I am a lecturer here at the law school at the University of Essex and a member of the Human Rights Center. I am also a director of the International Center on Human Rights and Drug Policy and one of the founders of our new Center on Mental Health, Human Rights, and Social Justice. And this is an area around mental health and policing is a new area of research and interest for me. And it connects to work that I have previously done with the former UN Special Rapporteur on the right to health. It's a wide open area in terms of sort of international human rights scholarship and research. And it's certainly a very topical, important issue and discussion happening in the North American context, here in the UK, and emerging in other parts of the world. A lot of times in the research that I've done around mental health and crisis support, questions are constantly asked, well, what's the alternative to approaches that we currently have today, whether it's through coercion perpetrated by police actors and law enforcement actors or within the medical field. And I think some of the conversations that I'd like to see more of is, well, what are the alternatives and the remarkable innovations that are happening around the world at a very local grassroots level. And that is what brought me and led me to the work of Kat Brooks and her team at Mental Health First in California. So as our sun is lowly setting here in the UK, it is rising on the west coast of the United States. Kat is an artivist, a community leader, a mother, and a passionate public speaker, that is for sure. She is the co-founder of the AntiPolice Terror Project, whose mission is to eradicate state violence against communities of color. And she's the executive director of the Justice Teams Network, a statewide coalition of organizations working to end state violence. Today, Kat will introduce us to the work of MH First that is happening in Oakland and in Sacramento, as I'm aware of. She might have more information on that. But Kat, it's a real honor to have you. We're very lucky to be able to fit into your very busy schedule. And without further ado, the floor is yours. Welcome.
Thank you, Julie, very much. Thank you to everybody for being here. I got a little teary-eyed there in the introduction because I continue to be in deep gratitude and sitting in a place of great hope as we have these conversations. I've been doing this work for quite some time. And if you would have told me even just 5 years ago that we were going to be having global conversations about redefining what public safety means and how we implement it, um, I, I don't know that I would have believed you. I'm gonna share my screen. As I explained to my host, technology is not my ballywick, but we practice. So hopefully, I think we got it. There we are. Yes? Okay. So yes, so my name is Kat Brooks. As she said, I am the co-founder of the AntiPolice Terror Project, which has chapters in Oakland, California and Sacramento, California. We've been in existence for about 8 years. I'm also the executive director of the Justice Teams Network, which is a statewide organization with 15 anchor orgs across the state, North, Central, and South. The mission of both of those orgs is to rapidly respond to, interrupt, and ultimately eradicate state violence in communities of color. And we do this through advocacy, working directly with impacted families and communities. We've always used communication as a strategy and not a tactic. We were very clear we needed to impact the public debate and the national narrative here in the United States about public safety and push back on the lie that police keep our community safe. We also engage in policy. A quick note there, we only engage in what we call radical reforms. And what we mean by radical is that they do not reinforce the status quo. So we do not support policies about training. We do not support policies about cultural competency, because those types of policies assert that policing is something that can be fixed. We stand firm in our belief that policing actually cannot be fixed. Its roots, its birth here in the United States were in the slave trade and the crushing of labor movements. So the job of law enforcement and public safety policy and practice has been to uphold race-based capitalism. And the way that it has done that is through the terrorizing, capturing, killing, torturing, incarceration of Black folks and other BIPOC communities. Excuse me, sorry. MH First, which is what I'm going to talk about today, is a project of the AntiPolice Terror Project, and it's a model for non-police response to mental health crisis. We are the only non-911 response models in both Oakland and the state's capital. And for us, right, the APTP is Black-led. And we were the cohort of founders. We've been organizing since 2009 together, since 2009, when a young man named Oscar Grant was murdered on our public transit on the platform on New Year's Day. And there was a lot of protest here, right? A lot. And a lot of folks will talk about 2009 and the organizing that happened around Oscar Grant, kicking off the next phase of the movement, right? We are definitely not in the beginnings of anything, though, you hear the young people say that as they take their rightful and righteous place in the streets. Black folks in this country have been pushing back since the first African was kidnapped and dropped on these shores, right? We stand on the shoulders and the work of the elders and the ancestors that have gone before us. So we were doing a lot of protests, thousands of people on the street, and that continued for quite some time. Until we had a conversation about what were we actually accomplishing through a reactionary model of response to state violence. And reaction is good, protest is good, it's critical, right? It impacts the public debate, it forces people to have conversations that they otherwise may be unwilling to have. And it provides a place for people to express their rage, to deal with some of the trauma. And it's an entry point for people into the movement. But if there are not solid next steps for that, right, then we have to question its utility. What's more, we started having conversations around, right, what does it mean when we tell our communities to not call the police? Because white supremacy creates harm, and white supremacy creates conditions, right, in our communities that then lead to what some folks called crime, and or violence. And then the state that created these conditions then gives you an apparatus that it says is going to deal with those conditions, which in BIPOC communities usually just means more terror and more violence. So what did it mean? What was our responsibility in telling people not to call the police? And not only that, but people were calling us naturally, right? They were like, or going on Facebook or social media, tracking us down and saying, I don't want to call the police, right? But who do I call? And so our crew are trained in a bunch of things, dealing with trauma, dealing with crisis in community. Asantwa Boykin, who I'll talk about in a little bit, is a registered nurse and has been working specifically in mental health crisis for well over a decade. So we started like trying to address some of these things. And it was everything from mental health crisis to substance abuse issues, to folks in domestic violence situations who wanted a different way than the violence of the carceral state to deal with that. And we were like, okay, we need some actual models. We need to provide our people with some alternatives, because the other thing that we know is that what the data say is that there's actually no definitive data that show that more cops equals less crime. That's a lie. It's an absolute lie. It's one that's used by law enforcement agencies across the globe. What there is definitive data about is that more law enforcement, the increased contact between law enforcement and communities of color always leads to more violence. We started with, the team, because shout out, because I have the honor of often being able to be the face of the Anti-Police Terror Project, but the work, the brilliance, the genius is really the team. And so this is Asantwa Boykin, co-founder of APTP and the lead creator of MH First. And you see by that picture, she's a G. That's me. Daniel Kantarova is a psychologist currently living in Oakland. She leads a lot of our family support work and has really been instrumental in taking this conversation into larger communities, having conversations around mental health. And this is Rebecca Ruiz, who's doing a lot of the coordination of our volunteers. I should say that also, all of our MH First folks are volunteers, every single one. And so these folks volunteer. We're only open on the weekends right now because that's what we can afford. And we also want to be sure that we're scaling up appropriately. And we're open from 8 p.m. to 8 a.m. So they stay up all night long, fielding calls from community members in crisis. And when we launched MH First, I mean, we knew there was a need, clearly. We knew that the data told us that there was a need, because in the United States, almost half of all people that are murdered by law enforcement are in the midst of a mental health crisis. And when you intersect that data with the demographics of who's being killed, you see the numbers for Black folks in particular and BIPOC folks at large, just staggering disparities between their white and Asian peers. So we knew it was critical, and we knew that it was something that was needed. We in no way could have been prepared for how hungry our communities were, right? With very little funding for advertising, mostly through word of mouth. Not only did the phones immediately start to ring off the hook, but the amount of people that poured in to be volunteers continues to be absolutely staggering. We have trained close to 2,000 people in how to be mental health responders without reliance on the carceral state or militarized police. And not all of those people are volunteering for the program, let me be clear. We don't care about that. Just like people that reach out to us and they ask us for help developing their own models, we're clear that MH First is a model for Oakland and MH First is a model for Sacramento. These are the communities that we live in. You cannot take a model and slap it on to another community, right, just as is, because different communities have different needs. But what you can transfer is skills, values, principles, and infrastructure. And that's what we've been trying to do, is support people in replicating those things and then adding their own twist to it. one of the other things that has happened, and I'll get into the actual model in a minute, but one of the other things that has happened here in the US, which happens often as movements, people-led movements, people-powered movements gain momentum, is the state figures out how to co-opt it, right? How to gain control of it, how to water it down and slow it down as we're sort of barreling towards liberation. And that has happened here as well. And so we've seen things pop up, particularly around what we would call a co-response model. So what municipalities are really working hard to do is say, no. Okay, we get maybe cops shouldn't go by themselves, but they should just go, because after all, aren't people in mental health crisis dangerous, right? Aren't these people inherently violent? And for us, we're like, that's exactly the type of narrative, and that's exactly the type of ideology that gets people killed. And actually, no, most people with mental health diagnoses, and that's a whole nother conversation about Western medicine and diagnoses, people in mental health crisis are much more likely to be harmed by other folks than they are to harm other people. Quick digression, we just had a huge victory here with a piece of legislation, statewide legislation called the Crisis Act. And the idea of the Crisis Act was that we were going to take money from the state and give it to grassroots groups that were building alternative community models to mental health crisis, substance abuse, intimate partner violence, natural disasters, and intercommunal violence. And so things were sort of trucking along the first year of the bill, and it got to the governor's office, and they wanted to put the bill, house the policy, right, and the watching over of what was happening in the state inside of the State Department of Corrections, to which we very loudly said, hell no. And they said, well, if you don't do this, then we will veto the bill. And we said, we will tank this thing before we allow the foxes to watch the hen house. And literally someone in the governor's office, and our governor here in California, Gavin Newsom, has a reputation for being an ally to those of us working to, some would say reform, I say tear down and rebuild our criminal injustice system. Someone in the office said, but people in mental health crisis are violent, and all of our heads exploded a bit. And so we sat on the bill until this year, and they were stunned because policy is supposed to be about compromise, but we are not willing to sell our souls for so-called progress, and ended up passing legislation that's just going to continue to get people killed. So we held our ground, we grew our coalition, we organized the Crisis Act passed, and it's in the Department of Social Services. Which takes me sort of to the next point that I wanted to make, is that this is not just about the switching out of bodies, right? What we are interested in is radical transformation of the way in which we look at people in mental health crisis and deal with the response, again, particularly when that intersects with Black and brown bodies, for addressing root causes, for having conversations about the role white supremacy and race-based capitalism play in creating mental health crisis issues, and creating a community response. And if that is not what is going to happen, then we work to intervene and ensure that that is what happened, or that those things get shut down. And part of why it's not just about transferring out bodies is because we're clear, right? The medical industrial complex can be just as deadly to Black and brown and Indigenous bodies, right, as the carceral state or the prison industrial complex and militarized police departments, because of the reasons that you see here, right? Rooted in white supremacy and anti-Black racism. I mean, if you look at who has access to healthcare, who doesn't, what kind of treatment or supports people get when they seek it versus who doesn't. We have a model here in the United States that is very much about profit and not very much about people. Excuse me, sorry. We have a system here in the United States that's very focused on symptom management, right? So putting what I call putting Band-Aids on gunshot wounds, as opposed to holistic healing and prevention. We have another case here that we're working on right now where a young man, he's in his 20s with a very long history of documented mental health issues, assaulted somebody. And the judge, the PD, the prosecutors, they all know and have said out loud, this man does not belong in prison, but they can't figure out there's nowhere else. There's no human place, right? There's no place that was going to deal with his humanity and give him the care and compassion that he actually needs for them to send them to in California, which is supposed to be one of the most progressive states in this country. It also very much focuses on the individual as opposed to being inclusive of family and community, right? And we believe that you've got to wrap your arms around the whole community, around the whole family, everybody that is contributing and or being impacted by what is happening. And then we talked about the stigmatization versus trauma-informed, culturally relevant, and practices that are informed by the understanding of structural issues and social determinants of health. So I want to talk a little bit about the principles of our work. So collaboration and accountability to impacted families. So since our launch, the Anti-Police the Anti-Police Terror Project has worked very closely with families who have had their loved ones stolen by the state. And we've gotten more and more committed and more focused, right? Because we believe on this issue and on this praxis, because we believe that those that are closest to the problem are the ones that hold the solution in their hands. But state governments and other institutions very often, right, those are the very people that they are pushing away, ignoring, criminalizing, and demonizing. That said, we also hear a lot of rhetoric, right, for the purposes of funding, that organizations are family-led, impacted family-led. But if you lift up the veil some, you find that that's not necessarily true, that these families are trotted out, right, when it's time to tell their story, and then trotted back in while folks that have the privilege of college degrees are actually the ones guiding the work. So that's not our practice. We work in deep collaboration, and impacted families were part of shaping the MH First model. Conversations about anti-Blackness. And so I wanted to just quickly define what that means, right? So told you technology is not my bailiwick. Anti-Blackness, as we define it, is a globalized practice rooted in the belief that people of African descent are inherently undeserving of being treated with dignity solely due to being Black. Right, so we talk often that in this country, it is a crime to be Black and walking, Black and driving, Black and at school, Black and eating, Black and shopping, Black and breathing. And then that anti-Blackness manifests itself in policy and practice. Talked about this a little bit, right? About the importance of destigmatizing folks in mental health crisis. Another one of our principles is intersectionality, right? These issues do not exist in a vacuum. So the issues of state terror intersect with the issues of the miseducation of our children, intersect with the issues of not having access to healthcare, intersect. And we've got to be able to see these intersections and unite our movements and unite these conversations if we're gonna make true progress towards the world that we're all fighting to live in. This response model that doesn't rely on 911, we see as abolitionist practice, right? Like, so often in conversations about abolition, you know, folks, well, until the last 2 years, well, that can't happen. What do you mean getting rid of police and prisons? That can't happen right now. You can't do that right now. First of all, I want to say that abolition is much more than just getting rid of police and prisons. We're talking about abolishing white supremacy and capitalism and the wealth gap and right, all of those things. And so all of those things, surely you're right, are not going to happen tomorrow. That said, we can engage in abolitionist practice right now. We can create replicable and sustainable models that show the people that there is another way, that then excite them, right, about investing in alternatives, developing their own alternatives. And the more and more alternatives we have, ultimately, right, the less and less we will be in the grips of the carceral state. Harm reduction is another principle very close to our work. We are all about decriminalization, right? And cutting off pathways that lead human conditions, human pain, human trauma, response to human pain and human trauma, and the ways in which that impacts people's mental, emotional, psychological state, or their choices about things that they put in their body that are pathways to incarceration. Trauma-informed crisis response. That is a shift in how we even approach situations, right? It's not about what is wrong with them or looking at the thing in them that you were going to tweak or fix, right? Again, what are the root causes? What got us to this moment? Relationships. I can't say enough about this. I mean, that's the other reason, in addition to the hunger that was in the community for alternatives. APTP has been in community, building relationships, being of service, being held accountable, right, when we get it wrong, because sometimes we get it wrong. And so there was a trust there, right? There were people that were willing to pick up the phone and say, yo, this organization, APTP, is launching this program and you should get down with it because they do X, Y, and Z. These are some of the names of folks that we're in partnership with to do this work. No one organization can do it alone. That sort of goes back to that intersectionality point that I was making. Yes, right. So once MH First responds to the crisis of the moment, and then we look at, right, all of the things that got us here, oftentimes it also has to do, right, with housing or substance abuse, et cetera. And that's not our work. So we've got to be able to refer them to folks we know share our values and principles that they're not going to then, in a warm handoff, be with an organization that absolutely will not call the police and then hand them off to an organization that is going to call the police. And so relationships, shared values, and principles. I'm not going to spend a lot of time here. This is just a reminder, right, for those of you that are in this work or moving into this work. Self-care, taking care of self, taking care of each other. It's the only way we're going to sustain ourselves and sustain this movement, which is very different than when I was being trained as an organizer and we were taught to drink, smoke, work, die. That was sort of the ethos, right? Not very sustainable. Another big principle for us is that the folks that we are servicing, right, it is their determination for their pathway of safety. It is their agency. BIPOC folks, that's one of the ways that white supremacy holds on to its power, is the consistent stripping of our agency and self-determination, which erodes, right, at the very core of our humanity. And so when we respond to somebody, we spend a lot of time talking about what they want. Where do they want to go? Who do they want us to call? What is their safety plan? So a little bit into the actual teams, and I'm almost going to wrap up here. I do want to, as you guys are thinking of questions, I am not a clinician. I'm an organizer and I'm an advocate and one of the early dreamers that another way was possible. But I'm not a clinician. So if you're going to have clinical questions, please save them. I will get them to Asantawa and we will get answers back to you. But this is sort of the team, right? That's an operation on a fairly regular basis, right? And the people rotate in and out. So the core team is made up of about 10 people. And those are the folks that are like in the day-to-day weeds of ensuring MH First continues to roll. Clinicians, operations is like, our phone lines, what referral platform are we going to use, et cetera. Volunteer coordination, That's a huge job. And the volunteer coordinator is a volunteer. Identifying resources and outreach. And outreach, we canvass our communities, but we started to do that again. Clearly during COVID, we had to shut a lot of that stuff down. And then at any given weekend, we've got 40 people in the volunteer team rotation. And it's all these folks, right? It's people that have letters by their name, people that don't have letters by their name, people that have survived the violence of the medical industrial complex. You name it, legal support, broad swath of folks that are engaged and invested. During COVID, we were responding to communities, members in crisis by phone and social media. Now that many of our folks have been vaccinated, I should have updated this slide. We are offering in-person dispatch again. At first, we started with some parameters around when we were going to dispatch and when we were not. And for us, the number one factor for us saying we were going to dispatch is if there was high probability that law enforcement was going to be involved, or if law enforcement was already present on the scene. And so during COVID, sometimes that could simply mean cop watching, right? Showing up with a video camera, letting the person know that we were there and we were supportive, and putting the cops on notice that we were there. I'm going to tell another story, and I know I need to wrap up soon because of time. Guys, 2 or 3 months ago now, we were in, it was definitely summer, June, I believe. And I was in my living room and social media started to go off and phones started ringing. And a community member, a young man, had crashed his car into another vehicle on a residential street. He had been utilizing substances. Police thought that there was a gun in the car, and they had his car surrounded, and they were trying repeatedly to wake him up unsuccessfully. Here in Oakland, in very recent history, we've had 2 other people in similar conditions that ended up dead, Demaria Hogg and Joshua Pollock. So this community member called MH First and let us know, called APTP and let us know what was happening. And we were able to show up. His family got word, they showed up. We were able to provide mental health support in that moment. We were able to contact a progressive ally on our city council, get her to call the police chief, and we were able to convince law enforcement to allow us to send his mother up to be the one to de-escalate and help coach him out of the car. And ultimately, she was able to coach him out of the car. And, unfortunately, he was arrested following that, but he was breathing. We also respond to more than just mental health crisis. We do domestic violence safety planning, and we're actually getting ready to release a whole model on response to interpersonal violence without a badge and a gun. And then substance use issues and other mental health concerns. The team for when we dispatch is 3 people, usually a registered nurse or EMT, a security liaison, and then a mental health practitioner. And I say practitioner again because they may or may not have those letters behind their name. The first thing, right, is to figure out if this person is actually having a mental health crisis, or is there something happening with them, physically, medically, that is presenting as mental health crisis, such as high blood pressure. The role of the security liaison is to deal with police if they do show up, to keep them away from the person that we are there to service, because often just the sight, right, of someone in uniform with a gun on their hip can take it from 0 to 150 in a matter of seconds. Because, right, the thing that comes up is all of the trauma that they've lived in, having any interaction with the state, but also to deal with community members that may have shown up, right? Because All of us are infected with the disease of white supremacy, and all of us have to check and challenge our biases. And it's often, our community members that are stigmatizing and criminalizing fellow community members that are in the need of help, and they too can escalate situations. So that's the role of that person. We provide basic needs: food, water, transportation. Sometimes, in Sacramento, we have a clinic where we can take people who maybe just need to sit down for a second, who maybe just need the space to take a few deep breaths, right? Who maybe are just exhausted and overwhelmed from trying to survive this rat race, right? From being demoralized and dehumanized, right? Every single day. To be seen, to be heard, to be listened to. And we operate intentionally where and when the least amount of services are available for participants. So the reason that we have the hours that we have is that in Alameda County, where we are, and also in Sac County, the services that do exist often exist Monday through Friday from 9 to 5, as if you can schedule, right, mental health crises. And so after those hours, what people are likely to get is a badge and a gun instead of care and compassion. Always a clinician on call, right? So that our volunteers have the support that they need. Training on when to contact those clinicians. Our hotlines, the responders answer calls as well as social media messages. We also respond to calls and messages from bystanders. And we're getting a lot, more and more of those, particularly since the George Floyd rebellions and this conversation, though it had been happening. Shout out, to folks like Kara Page and Miriam Kaba. We launched the Defund OPD campaign with a demand around mental health here in Oakland 7 years ago, but it exploded into a national call. Following the rebellions. And so more and more people are calling us and like, I don't want to call a police. Can you come do whatever it is? Sometimes we can, sometimes we can't. Sometimes the work is about finding someone who can, right, deal with a particular situation that we don't have the skills to engage with. A little bit about our shifts, but I want to sort of wrap up. Everybody is trained, right? So I mentioned that people are volunteers. Everybody is trained, and these are the basic building blocks of that training, right? Around our principles of our work, the decolonization of conversation, and analysis of mental health crisis. We work with white folks, right? But we are led by Black folks and BIPOC communities, and our partner community, Ready Corps, they have a training on divestment from white privilege and how to weaponize white privilege. And all of our white volunteers also have to do that training. Trauma-informed crisis response, training around substance use, DV safety planning, medical problems that mask this mental health crisis, first aid, cop watching and de-escalation, and Narcan administration. All right, I think I'm going to leave it there. We've got about 20 minutes, and I would love to actually get some questions from y'all. So I'm going to stop sharing my screen.
Thank you very much, Kat. Let me start my video. Fantastic. And, as somebody that has been for the past 5 years or so, really kind of living and breathing in sort of the global space around mental health and human rights. A lot of the statements of problems that you have in your, locality really resonate with a lot of the global tensions and discussions that are happening around, really how we understand and respond to mental health and mental health crisis. So, I think it's really meaningful for a lot of people here to see the shared kind of struggles and challenges and the hope there is in sort of galvanizing community action and really developing innovative alternatives. that address these issues in holistic, meaningful, and really radically transformative ways. So hats off to you. We have a couple of questions already coming in, but I did want to bring in a colleague of mine, Alberto Vasquez, who's a fellow here at the Human Rights Center, and has been also working on this issue quite a bit for many, many years, to reflect and perhaps share a few questions that he has with you. And then also after Alberto, I'd like Carlos, if I've permitted you to take the floor, but it would be great, Carlos from Human Rights Watch, if you want to sort of reflect as well and ask Kat your questions. So Alberto, to you.
Thank you, Julian, and thank you, Kat, for this presentation. Actually, as I was thinking through your presentation, how you have managed to cover two of the key questions we're having in terms of implementation of international human rights law in the context of mental health, which is one of the two pressing concerns we have, is how to avoid coercive practices in mental health services. And the second one is how to prevent police intervention. In both cases, we're talking about the power of states. And you're coming from a practice that is more based on the community that is helping us to move forward. But I think there is something extra that you mentioned that I would like to ask is, you mentioned the issue of you don't give diagnosis or administer medication, which seems to me it's a way not only to destigmatize mental illness or persons with psychosocial disabilities, but also a way to demedicalize responses to crisis. And it seems to me that in every effort we see, or most effort we see around the globe to try to provide a non-coercive response to a mental health crisis, it comes from the health sector. And what I see here is something that articulates with clinicians and support, but also articulates with the community in a way that actually demedicalize the intervention, because it's more about the individual than identifying the diagnosis and identifying what set of course of intervention from a health perspective should be done. No? So how do you see that? Do you see? So I will have two questions for you. One is, how do you see this demedicalizing approach in your practice? If you think that's something, I think it came from what you presented, but I would like to know better, how did you come to that? And the second one is, if you see your practice as also as a response, as an effective response to the coercive system in mental health, in the mental health sector in general.
Hold on, Alberto. The first thing, I just very want to quickly respond to Julie, what you said, and just say, of course, right, we're seeing the same things, because and unfortunately, the impact of U.S. imperialism isn't limited here, and the white supremacy and the vestiges of colonization and its horrific impacts on communities of color is everywhere around the globe, which is a testament to why these conversations are so important, right? That we're talking across so-called borders. A couple of things, Alberto, and one. It has to be community-led. So I talked earlier very briefly, right, on the state's co-optation of our work. We have had to shift a lot of our organizing resources and strategies and tactics and mobilizing to deal with those, right? So that we ensure that community, and not community that the state approves, right? Or the community that they work with, but that community that shares our values and principles has our hands on that. And that's a big fight. It's a big struggle. I want to be clear. I didn't say I don't believe in Western medicine diagnoses. I don't believe that is the beginning, middle, and end of the conversation. I think it is a very limited, I don't think we see, it's a very limited box. It doesn't take into account all of the things that led up to that moment. It doesn't look at the trauma and the wounding and the damage and the dysfunction that white supremacy creates, right? What does it mean to your mental, spiritual health as a Black person, to walk through life every single day knowing that you were hunted, knowing that you were prey, knowing that any moment you could be killed for, as I talked about earlier, being Black and having the audacity to breathe in public air. What are the impacts in fighting to have secure housing for your children? What are the impacts on our mental health? If we can't eat, right? We actually know that is documented, right? You need food, water, shelter in order to have a stable and balanced mental health space. We need to be having that conversation with the same energy that we're talking about, drugging and incarcerating our people who are responding in a lot of ways to the conditions that the state creates. And so it is Western, I think that Western medicine has its place, it has its role, but it is certainly not a friend to BIPOC communities. And we need to engage movement, spiritual practice, right? A lot of the stuff that we're doing in terms of community care and response to community crisis, they're based on the practices that our elders were engaged in forever. This stuff isn't new, right? It's about mainstreaming that again, and us mainstreaming it, not the state mainstreaming it. Efforts, and then I'm sorry. So that's why we came to that approach. I mean, it was also our ethos from the beginning around organizing against state violence and realizing that the state was never the answer to our health, be that medical, the education, housing, et cetera. There's nowhere here in this country, and as far as I know around the world, where the state adequately, effectively, and equitably, holistically provides those things for their people, and very much believe that that's the job of the government, and it fails miserably all of the time. And then I'm sorry, the second part of your question, I can't read my own writing.
The second part of the question was about if you see this process as a way out of coercive practice in the mental health system.
Absolutely. I mean, our intention is to make coercive responses irrelevant, and that actually being seen as the criminal act as opposed to someone having a moment right in the middle of an intersection. Our ultimate goal is to shut off the mental health crisis to prison pipeline. And we believe through demonstrating alternative responses rooted in justice, equity, and humanity, that if people can see an alternative way, that most people are good people. And that's part of the movement building practice, right? The problem is that the alternative models haven't existed, right? And so our conversation around public safety, we've only had one choice, right? And then that's unwarranted or unnecessary incarceration, militarized policing, and then of course, right, all of the ways in which the state figures out how to funnel Black and brown bodies into institutions, because to not have to deal with us, and also as a way of controlling our communities and preventing movement building and liberatory struggle.
Thank you, Kat. Carlos, you have the floor.
Thank you, Julie, and thank you very much, Kat, for your presentation. My question was around the Crisis Act and AB 118 that Human Rights Watch also supported. And we were wondering, how are you going to use this new legislation for the issue of follow-up? I think it is important to have crisis units for responses, immediately, that are human rights respecting, but it is also necessary to sort of like do a follow-up to folks that have been living through a crisis, because if you have no housing, there's an issue with that, or getting a job or getting other services, chances are that the crisis is going to build again. So I think that those are things that are important to follow up. And I was wondering if you think that AB 118 would be useful for this. And also an announcement that we're going to put together a good practices piece in Human Rights Watch, highlighting the Gerstein Center in Toronto that has a model for emergency responses also to mental health that we think it is human rights respecting. and that we think that it has us it's a step forward from other models in the US, for example, the Cahoots model. No, but I wanted to say that, and we'll see your reflections on the follow up. And thank you again, and it's a pleasure to see you again, Kat. Thank you, Julie, for the space.
Thank you for your question, Carlos, and for your work. About the Crisis Act. So the Crisis Act came on the heels of some pretty intense policy struggles that we had and won to change the use of force policy in the state of California for the first time in 150 years, which removed sort of the excuse that cops could be like, well, I feared for my life, to they, for the legislation, not happening in practice. Another panel, another time. Have to exhaust every single possible option, right, before they can kill somebody. Big, hard, long fight. But again, as that was wrapping up, APTP was having this conversation, right, about creating these alternatives. And so I went to Mark Philpart, who is a director at PolicyLink, and so you think we can do something else? Right? You think we can get the state to actually pay community groups and members who are already doing this stuff for free, to give them some dollars to expand this, right? Because the folks are hungry for it. We had, we're in the process of getting ready to launch MH First in Sacramento. And it took off from there. And I lead with that just because right. But so I've got some bias, and it's super close to my heart. Not nearly enough. It's only 10 million, right, US dollars that are going to go out. So it'll be about $250,000 for 5 groups to be able to do this work. And so the next legislative session, and I'm going to get to your question, Carlos, I just want to provide some context. The next legislative session, right, we're going to be pushing for more money, right, more divestment specifically from police and prisons to go into these models. And we're going to be able to argue for those dollars based on the data that we're going to be able to call from the programs that are going to be developed and implemented across the street, showing that it works. Already mountains of research that say that, but we always have to prove and prove again that we know how to take care of our folks. So I don't think that the Crisis Act is a funding mechanism. It's not a program developer, right? So the idea is that the money will go directly to these community groups. So let's say the money came to APTP, right, for us to expand MH First. We have that practice of follow-up, right, I spoke about earlier, right, and is why one of our principles is intersectionality, and hoping that other groups will too. We're doing a lot of consulting for groups across the state around best practices, and of course we'll encourage people, but I don't believe, and James Birch, who's our brilliant policy director, who made that language so super strong, which by the way, it prohibits collaboration with police, right? You can't do it with Crisis Act money, which is like unbelievable, unheard of, but it doesn't dictate programmatic development for the reasons that I talked about earlier, right? You can't take a model and just say this is how you have to do everything. There's values, principles, and infrastructure, which are the conversations that we've been having with Cahoots as well, because while they are being uplifted and we love them, and great, amazing work, Eugene, Oregon, where they were born and operate, is like 99.9% white. Right, so the way in which cops engage those people is different. Long-winded way of answering your question, but I hope it did so in a holistic manner.
Thank you so much, Kat. And I think you spoke to a couple of the reflections I had around sort of these one-size-fits-all approaches and the hunger for alternatives, and it is a global hunger, but oftentimes, the idea is, how do we replicate? How do we scale up? And how do we basically transfer and cookie cutter these approaches, and sometimes expand existing ones? Because the problem is there's just not enough resources. It's not the foundations, the values, principles are problematic. And so I think that you've really hit the nail on the head of sort of the conversations that need to be had about, so what does a rights-based approach to crisis response look like? It isn't about one specific model. It's about the values that underpin these models and how they resonate with these supposed universal norms. It's great to hear that Human Rights Watch is also working on developing sort of a community of practice and best practices to help our imagination, to heal our imagination and expand it to see what is possible. And we do have also joining that is here, I think they're still here, is some wonderful colleagues within the World Health Organization and their mental health and rights team that have also produced a wonderful best practice document that is starting to look at a variety of different sort of alternatives and sort of rights-based alternatives to mental health in a variety of contexts, from peer support to work in sort of existing mental health systems. And so I think it's great to see sort of the global, the local, the regional, all really sort of looking at what underpins these alternatives and what makes them work. And so my question to you, and we do have to wrap up, but when you talk about the research and having to prove yourself over and over and over again, it's something that resonates with a lot of us who work in human rights, because, you know, people want to say, well, what's the evidence that human rights works? You know, what's the evidence? Like, we have to provide evidence that not torturing and killing people is a right approach. But I do think it is a question of, how do you evaluate your programs and how do you measure things? And I think what our idea of how we measure success is completely different if we take those values and those new sort of radical approaches. And so how do you work improving in a system that is looking for biomedical indicators? They're looking for indicators that aren't necessarily human rights friendly. In fact, they might themselves be human rights violations. How have you evaluated your progress and your success?
Well, a couple of things. The first thing was, and I know you know this, Julie, so this is not correction. I just want people to hear it. There are absolutely enough resources in the world, right? To do this. It's just where people that hold the power are directing those resources, right? And I know folks know that, but I think it's important, because often those of us on the left, or those of us that are fighting for human and social human rights, right? We move from a place of lack, right? As opposed to demanding our equitable share to the resources to heal and build our communities. So we are just starting our evaluation process, right? Evaluation can be super expensive. We were approached by an organization, Human Impact, that is going to do it for free. And we are having this very conversation, right? So what are the metrics that balance it out, right? Because we've got to have metrics that are going to resonate when we're advocating, say, for more crisis act dollars, right? Things that policymakers can understand. And we need to have data that proves that we can have healthy, safe communities without reliance on the violence of the carceral state, right? So that's going to look like what was police, what were people called in the police for, right? And did the number of calls for mental health crisis shrink, right? And by how much? How many people were we able to interrupt from going from having a mental health crisis on the street to being tortured for having mental health issues in jails and prisons? It'll look like how many volunteers, and particularly volunteers from the communities that are most impacted, were we able to not just train and recruit, but keep with us. Community support, like I would like to see us, do a polling or a survey of communities that we're going to enter into in the beginning, and then a year later, right? And what does community support, engagement, et cetera, look like? And yes, longer term, I see Michelle Funk saying longer term outcomes as well. Yes, but that takes a minute. I mean, people, I'm not a researcher, but you all know, right? Like 1 year of data, not so much. So probably won't be able to look at longer term outcomes for another year and a half or so.
Great, thank you very much for that. And you are, relatively new, so yes, longer term outcomes will happen. I think, for you, it's you built something that seems sustainable. You have an uphill battle at all times, but I really wish continued success in this work, and hopefully we'll get to meet you in the coming year.
I hope so
Person.
too.
Yes.
Yeah, that would be amazing.
But I think all of us, I think I speak for everyone that's been here today to express our gratitude and our solidarity. It takes a lot to build something as amazing as you've done, Kat, and your team, and to have sort of this success and this vision is really inspiring. I hope that these conversations can continue, not just in California, but throughout the United States, but also around the world. Thank you all for joining and your attention. And I look forward to this being the beginning of a long collaboration and discussion. So
Absolutely.
thank you all.
Thank you so much for having me. You all have good days or good evenings.
Have a great
All right.
evening and a great day.
Bye.
Bye, everyone.